diagnosis. But Dr. Davis is here joining us. He is a child and adolescent psychiatrist, something that I definitely don't know very much about. I work, below the neck kind of thing. And I think most of us don't do very well in psych. We refer a lot of those people out or wish that we could. So he works particularly with maltreated and underserved kiddos, and he's done that his entire career. So what a servant to New Mexican kiddos. His expertise is in psychopharmacology. I can't even spell that. He serves particularly emotionally disturbed kiddos, treatment of delinquency. I had to ask him what that means, and he said that's about externalizing behaviors, running away, being impulsive, and trying to help those kiddos get back on track. He's got a particular interest in child abuse and neglect and how it affects their neurodevelopment going on. So I asked him what his fun fact was, and he said, you know what? I've been doing this 35 years, and I really did not know about child development until I had 6 grandkids. So with that, we'll introduce Dr. Davis, and he's going to take it away.
I'll go up there. Yeah, I think so. Is this on? Oh, it is. Okay. I'm going to stand up here, at least for the time being. It's nice to see you all. It's a pleasure to be here. I wasn't sure, 5 o'clock on a Friday, you guys are devoted people, and I'll try it. And not only that, we're talking about the pharmacology of ADHD, which is interesting to those of us who are doing it and to me, but I'll try to make it robust as possible to hold your attention. If you need to stand up, you can't yawn, but you can stand up and walk around if you want to. I don't know how long you've been sitting there. For all I know, it looks like a captive audience. You might have been here for like hours, maybe 12 or something like that. Okay, I just wondered, I want to make sure I know who I'm talking to. I know it's nurse practitioners, but I wonder how many of you are already prescribing for ADHD. Any of you? Yeah, a few of you are already doing it. With kids? With kids? Great, that's good. Glad to know that. That might make how we approach some of this, but not too much. Let me see here. You know what? I think I'm just going to advance. It like that. I'll figure it out. There are some, these are just articles. I want to tell you before we even start that there's a lot of material here. If you realized how much there is written on ADHD and the pharmacology of ADHD, you would be stunned more than disappointed. So there's a lot written on that, and I thought I want this, the PDF of this to be something you can use going forward. If we don't get through everything, that's fine. There should be a lot on here that's useful to you, like lists of medicines, tips for how to engage the practice of prescribing with kids and that kind of thing. These are 3 articles. These are pharmacology review articles. Every single one of them is good and readable. They're really worth reading if you do it much at all, or if you're interested in pharmacology. And then the bottom 2 under DEA Schedule 2 prescribing, that is articles on being legal, basically is what it is. So I assume that those of you that are prescribing for kids are conversant with Schedule 2 kinds of medications and all the rules that apply to those. So when it comes down to, when you're talking about ADHD prescribing, really you're talking about the 3 components of doing it accurately, having a correct diagnosis, and approximately or correct right medication at the right dose. You're talking about doing it wisely, because that means you have to know when to prescribe and when not to. There are times when it's better not to prescribe. You also have to know when to quit, when you're at the end of your rope, or the patient is, or you're at a relatively high dose with either lots of side effects or no real beneficial effect. And then you also have to prescribe legally. I'm not, I'm never the kind of person that actually likes to send a slide up here on the DSM-5, and that's not really what I'm doing here. Just remember that when you're looking at and prescribing for ADHD, there's two major symptom clusters. The first is hyperactivity and impulsivity, and the second is that inattention. Those don't always go together. I mean, you can have an inattentive type, or you can have a primarily hyperactive impulsive type, or you can have a combined type. It might make some differences in how you prescribe for these. But pay attention also to the limitations or the exclusionary kinds of criteria. There are things like if it's not present in more than two settings, or two settings, more than one setting, at least in two settings, then it may not be ADHD. It may be like anybody who does an incredibly boring task will have, you get restless, you get up. I mean, it's like all of us at tax time. If you know what I mean. Everybody has ADHD for the month of March and a little bit of April, and then it kind of goes away, if you know what I mean. So if you're faced with a task, and that's why learning disabilities are difficult for kids, is because they can't really do the work. And what do you do if you can't do the work? You poke the person in front of you, or you tell jokes, or, if you know what I mean. And so you have to pay attention to those exclusionary criteria. And then the other thing is that now its symptoms should be before 12 years of age. That used to be 7. The point of that is that ADHD in its real purest form is a neurological disorder. And if it's present, it's going to be present early on. Frankly, I think the 7-year-old cutoff was better than the 12-year-old cutoff. But the point is that if a person comes to you in their junior year of high school and suddenly has ADHD, well, it's probably not. It's probably not. It's probably angst over a breakup or fear of college or something like that, if you know what I mean. And so it's probably not if it happens that late. The only reason I give you any of this prevalence is because I just want you to be able to ballpark your own diagnoses on this kind of thing. So if every patient you have is ADHD, then you're probably a little outside the range for the diagnostic criteria. That's true of everything, you know what I mean? So supposedly the prevalence of ADHD is between 5 and 9%. That is a huge range when you think about it. That's not like something like schizophrenia, where there's 1% of the population, and I don't care whether it's in Albuquerque or Bolivia, 1% of the population, because it's a neuropsychiatric condition. ADHD is soft. It's soft neurological is what it is. They say that the prevalence is 5.29% worldwide, but the only reason that's true is because they take the entire world and average it out, if you know what I mean, because there is a huge variation regionally, which I'll show you in just a second, in the US about how this is diagnosed. Males are 2 to 3 times, some people say 4 times more likely to be diagnosed with ADHD than females. To be perfectly honest, I think that's an insult to both genders. For one, males, they're more externalizing, and so they tend to be the squeaky wheel, and they tend to be prescribed more. But on the other hand, the girls in the classroom that are quietly not paying attention and sitting in the back row are also not getting any attention. So it's probably, those figures are probably a little high, to be perfectly honest. There's a lot of diagnostic ambiguity. I'll just put it like that. I'm just throwing this up there because you can see how high the prevalence is. The top one is the prevalence for diagnoses. Why it's higher in, you could make up anything you wanted out of this map, but why it's higher in Mississippi, Alabama, Georgia, Louisiana, I don't know. South Carolina is a big one too. And then the same way, I'm making a point here, is that this is the variability that you see. It's a matter of who's paying attention and who cares. It's not the kind of thing where a child is going to come to you and say, "Doc, I speak out of turn constantly. I interrupt my parents. I'm not making good grades. Kids don't have that, usually that concern. It's usually somebody else's concern. It's usually first and foremost, it's the teachers or it's the parents. So you got to remember that that's what you're looking at in this map. And that's also the same group that is prescribing for this. There's a high degree of comorbidity with ADHD, and I mean a really high. 2 out of 3 kids are going to have some other mental, emotional, or psychiatric or behavioral disorder. What that tells us is, if it's got that kind of comorbidity, and it's not very often seen, and like 66% of the time it's seen with something else, that tells us that it's a brain disorder that is very non-specific, and that is true about ADHD. It oftentimes goes with something else. That's why it oftentimes goes with mild head injuries. It's associated with the prematurity because it's a little bit of a miswiring is what it is, because it takes a very fine-tuned set of frontal lobes to sit in class and learn math, frankly, because those are difficult things to do. And if there's just minor disorders, it shows up. It used to be called minimal brain dysfunction. MBD is what the name used to be called for ADHD. I guarantee you I'm the only person in this entire building that even knows that. And it seems a little insulting, but that's kind of what it was. It's a minimal brain dysfunction. Those comorbidities, I'll tell you in a minute, they'll sometimes confuse the diagnosis, and they require treatment in themselves. I highly recommend you treat comorbidities. Frankly, I always treat comorbidities first. I don't launch into the ADHD itself until I've cleared the weeds out. Like if the kid is depressed, the kid is anxious, treat that before you get to the ADHD is my personal recommendation. A lot of these are my personal recommendations, and you're free to not follow them if you want to. There's a lot of confounding conditions. And by confounding conditions, I mean things that look like ADHD, which are not ADHD. If you think about depression, kids with depression, they have low motivation, they don't pay attention, they don't get along with other kids, they're irritable. All of that can be mistaken for ADHD, but it can be anything on this list can be mistaken for ADHD. Anxiety can be. I didn't say that in the last slide, but anxiety, 1 out of every 3 kids who's diagnosed with ADHD has anxiety. So that's high comorbidity, and anxiety looks a lot like ADHD in some ways of looking at it. I'm not going to go through all these, but I just want to point out that this also can be a purely physical disorder, like a brain condition, like a speech disorder, a hearing disorder, a language disorder of some kind, or a learning disability, or it could be anything from lead exposure to other kinds of drug exposure. So always rule out everything. My point, and this is a big one, I think, is that ADHD is a diagnosis of elimination. It's the last thing. Don't start with ADHD, start with everything else and work your way toward ADHD and check everything else, frankly. Okay. The most common thing, and I'm not going to perseverate on this because this is my area of interest and it's kind of the only, the thing that I always stay on, which is abuse and neglect. Early maltreatment of children is a brain disorder. It causes disturbance of development. It disturbs the trajectory. It clamps off the full development of frontal lobes. It affects impulsivity. Early abuse and neglect is a regulatory disorder. Therefore, it looks a lot like ADHD. And consequently, kids who are abused and neglected, whether they're in custody or they've been in custody with the state, they oftentimes are diagnosed with ADHD, and it oftentimes is not what it is. If you look at the incarcerated population, which are basically kids who were previously in protective services, 94% of them have histories of abuse. So do you treat it? Maybe. I know it's a terrible answer, but you get, when you're treating inattention and hyperactivity and impulsivity in a kid who has been abused, oftentimes you don't get the response you think you're going to get. Because trauma is a hyper arousing kind of agitating kind of experience for kids. Oh, wait, hold on. Because it is a hyper-arousing kind of event for children, oftentimes if you give them a stimulant, you get a counterintuitive kind of escalation of their. All of us who have worked with kids who are abused and neglected eventually get that one way or the other. Reasons to medicate. Usually we think of the reason we're medicating is because the kid is having problems in school, right? I mean, that's usually the complaint, that the teacher says this child is not paying attention, is always up and running around and interrupting others. The parent responds and says, wow, you know, this kid is like that at home as well. So we think about it as an academic problem, but it also has huge social, interpersonal kinds of consequences. Kids who with ADHD, just like adults with ADHD, don't make friends as easily, they don't keep friends as easily, they don't stay married as long, they don't hold their job as long, and they don't do well in school. And so what you're really doing with ADHD is it's kindness to treat kids who have that. And the reason it is because it reduces all the negative consequences. You know, nobody wants to be the kid on the block that nobody wants to have over, or the kid in school who's always in trouble. And so you building self-esteem and confidence when you help a kid get past this. You also improve the home life. You improve the relationship with the parents. I know I sound like a salesman for treatment here, but what I'm trying to do is retrack it and say, this is the reason you prescribe. You prescribe to give the kid a better life. And whatever you do toward that end, it's certainly like improving the relationship with the parents, that is going to help that it's going to help that child's life. That last entry, it says ADHD is social capital. You do get a lot of teens. This is just between you and me and everybody who will ever see this, but it's a popular diagnosis, you know. It's like bipolar disorder, which is also grossly maybe diagnosed 40 times what it actually is by some figures. ADHD tends to be a popular diagnosis, and if you go to the doctor and it explains everything, you know, for me, it explains, why do I forget things? Why don't I pay attention? How come I'm not listening to you? It explains everything, if you know what I mean. And so it can be a popular diagnosis. Make sure you make your own decision about whether a person has that, whether a kid has that. Now, here we are. We finally got to the medicines. There's two primary stimulants, just two. Out of all the 45 medicines there are for ADHD, there's really only two primary stimulants. The first is methylphenidate, and all the rest are permutations of these two. And I'll show you how they do that in just a second. The first is methylphenidate, which is also Ritalin. Ritalin is a reuptake inhibitor of dopamine and norepinephrine at the postsynaptic receptor, which basically means it's increasing norepinephrine and dopamine. It's increasing activating neurotransmitters in the synapse, and it sparks, if you know what I mean. All you have to do is do it like a couple of nanograms and everything changes. Amphetamines, which is the same thing as dextrine, which is Adderall, basically, directly stimulates the postsynaptic receptor. It's not a reuptake inhibitor. Now, the reason I bring this up is because sometimes, for reasons that nobody's clear about, you will get a much better response to one of these stimulants or the other. You don't really know which it is. It's trial and error. You can start anywhere you want, and you'll want to switch sometimes. And maybe that's the reason for that, but it's a different mechanism. They assess that those are 60 to 80% effective. You know, I've been taught that for as long as I can remember. But remember what that means. When they're about 70% effective, that means since the major complainants are parents and teachers and other people, not the child. It means that the parents and the teachers feel better, partly. I'm not saying it's a mythical disease, but I am saying you have to remember how they determine effectiveness. So that was the pharmacodynamics. There's really nothing, how exactly that tunes up the brain is clear and not clear, if you know what I mean. A person is more alert, more targeted, has better impulse control. It's the opposite of what you would think. But remember, this is a small dose of stimulants. The pharmacokinetics, meaning how are these medicines processed by the body? How long do they stay? And how long does it take them to release, and how are they eliminated? Is it renal or is it hepatic? All those kinds of things falls under pharmacokinetics, and that's where the art is in these stimulants. There are many, many permutations of the physical and the chemical characteristics of these two stimulants. And what they're doing basically is extending the time or tweaking the time. Tweaking is probably the wrong word when you're talking about stimulants, but changing the amount of time it takes for these things to be released. So methylphenidate, immediate release, takes about 2.5 to 4 hours. Dexedrine, which is also Adderall or dextroamphetamine, that takes about 3 to 4 hours. They're about the same. If you notice that time, that's why originally every kid who was on stimulants would take a dose in the morning, then you'd have to redose them at noon. And so you'd spend a lot of time communicating with the school and signing paperwork to allow the school nurse to give these medicines. That's what they've eliminated with the release, with the timed release. Adderall is not just dextroamphetamine, by the way. And the reason it has a slightly slower response than just Dexedrine, because you can prescribe just Dexedrine. The reason it has a slightly slower is it's tied up chemically. It's two isomeric salts of the same stimulant, and they just slowly, it takes longer for the body to process those, and consequently they get a slightly longer duration. There are problems with prescribing stimulants, as you might guess. Addiction is oftentimes talked about. Frankly, addiction, it's not rare, but it is kind of unusual. And the reason why is there's many, many more powerful stimulants out there, street drugs, many things that are much more of a rush than a prescription Adderall or prescription Ritalin. And so addiction per se, and you also have to realize it's a lot of trouble to get to a doctor to get them to prescribe this medicine, to get it on a routine basis. It's just a lot of trouble to get it that way. There is some street value. I know you can look up the street value, and there's a fair amount of street value, more than I would expect, actually. But it is true also that individuals, children who have ADHD, and the adults that have ADHD is continuation of their childhood problems, they are slightly more likely to abuse substances. But when you think about it, that's part of the diagnosis. They're more impulsive. Their judgment is not as refined. They have less inhibitory, and so it kind of makes sense. Treated, they're slightly less likely than average to abuse substances. So addiction is not the real problem. The real problem is diversion. Unintended consequences such as misuse. High school and college students will use them for academic performance enhancement. They'll also use them for sports performance enhancement, which, I had to actually look up a couple articles on that to believe it. I just did not think, but it makes perfect sense, But so it has that kind of misuse potential. It's also used recreationally as a very light kind of buzz. The nonspecific effects, and here's the truth about stimulants, the nonspecific effects for people who don't have ADHD are very similar to the effects for those kids that do have it. There's a slight mood elevation, and you're more productive. See, now every one of us wants it right now. And you're thinking, whoa, would it help me listen to? And it could, but I don't have any samples with me. And so there's a lot of studies on that too, that at the same doses and on some similar tasks, stimulants are going to have the same effect on a person without ADHD as they do on a person with ADHD. Now that doesn't mean that ADHD is just you on a bad day. That is not what we're saying here, because there is a wiring dysfunction that is primarily frontal or frontal temporal, and you are tuning it up. And the truth about kids on ADHD is that not that they're overstimulated. You would think that hyperactivity meant that they're frantically overstimulated, but the fact is they're kind of internally in terms of neurologically, they're kind of understimulated. And then understimulation is what makes them constantly move in an attempt to keep themselves going. So it's the reverse of what you think. And if you stimulate, it's like maybe us before we have our first cup of coffee in the morning. You know, you can't think of anything and you're restless and you don't know what to start. And that cup of, coffee kind of clarifies it. It's a different drug, but it's some similar effects. There are side effects to stimulants. Those side effects, some of them are, they're talked about a lot, I'll say that. Like addiction, they're discussed a great deal. The side effects are not as prominent as you would think they are. One of the big ones that people worry about are decreased appetite and weight. And in kids, they're skinny little things to begin with. And so you worry about that if a kid stops eating or delays more likely the eating until later in the day, because kids will do that. They will not get hungry. They won't eat their lunch at school. Then they come home and they totally scarf up everything in the refrigerator and they eat a big meal. And I know some kids who will wake up, at 12 o'clock at night and make a ham sandwich. In order to sort of like get that calorie. So they tend to recuperate. But if they have pronounced kind of anorexia, then that's a dosage problem. That's a medication problem. It's something you should work on. Growth suppression, people worry about that too, that you'll make people that they won't achieve their full height. They've studied that. There's 2 really large studies. One of them said there's no difference whatsoever between kids who consistently use stimulants. The other one said there might be a diminish by about 1.5 centimeters. And so it's not really a big problem. The real big problem is the kid needs a normal life. He needs to be able to sit there and have some lunch. That's the issue, not growth suppression. Sleep disturbance, it's another dosing problem. If the kid still has an active dose of a stimulant at sleep time, then that's, our fault as prescribers. I'll get to the cardiovascular kind of effects in just a second. There's always the worry that it'll precipitate a mania or a psychosis. I'm sure that has happened in the history of psychiatry, but it doesn't happen very often. And it doesn't usually happen at the kind of doses you're giving. And it also doesn't very often happen unless there's abuse going on. That's much more likely. It will, though, increase anxiety. Kids who have an underlying anxiety disorder, it'll make that worse. They will be wired and they'll find it to be very uncomfortable. It can unmask tics, I should say. It doesn't very often cause tics, but it will unmask them. That's why with Tourette's, which is oftentimes comorbid with ADHD, neurologically, it's very similar. With Tourette's, you can unmask those tics by starting a stimulant. And if you want to remask them, just stop the stimulant. It'll also cause agitation. Usually that's a dosing problem. If kids are picking at their skin or peeling their nails or just pulling their hair, trichotillomania is common in kids if they've got too high a dose or if it's just not the right medication for them. There are very few, however, drug-drug interactions. That is unusual. You can read them, but you're not going to find many that are very significant. One specific side effect that I want to mention is seizures. You will see, because ADHD is comorbid with a lot of other neurological disorders, that child might more frequently, not frequently, but more frequently than average, have a seizure disorder. You would think that stimulants would make that worse, but they don't really. And so I'd really built this whole slide just to tell you it's not a problem. They have looked at this over and over again, and it just doesn't do it, even though it makes common sense that you would think that it does. And again, though, when seizures do happen, it's usually in the context of abusing stimulants and misusing their prescription. There is a black box warning on, well, there's a black box warning on every psychotropic virtually. You know, we're targeted, I think, by the FDA. But usually those black box warnings are for suicidality. And it's really not just psychotropics, all the antidepressants, all the SSRIs, but all of the anticonvulsants. So neurologists have the same problem. It's anything that changes slightly your level of function can cause an increase in suicidal ideation. That's not what this is. This is a cardiac. So between, I think, the mid-90s and 2003, there was a number of what they considered sudden deaths. There was 20 in that 10-year period, which, you know, if you think about statistics and think about the FDA, that's barely even measures. So it was rare, and all of those, I think every single one of those was in the context of some underlying heart abnormality. So it's not that stimulants cause sudden death, but it does mean something, though. It means that when you give stimulants, assiduously take a family medical history and a past medical history for that child and document it, because you want to be practicing for a long time. And if there's any suspicion, you know, if they say, well, you know, Uncle Ralph did fall dead in the middle of a football game one time, and if there's anything suspicious at all, get an EKG and document that. That's all you really need to do. You're probably not going to find anything. But if there is sudden death in the family or other kinds of arrhythmias or cardiac abnormalities, you know, get an EKG, practice defensively. That's my strongest recommendation. Principles of prescribing. These are my principles, and they're not rules of prescribing. They're just suggestions. I usually start slow and small with an immediate release dose. If the kid, and the younger the kid is, the more true that is. If you got a 6-year-old that you're going to try that on, just like break a capsule under their nose and let them sniff it first, because you can get a very bad response to some of these stimulants. It doesn't happen very often, so it always catches you by surprise. But you want to know if it goes fine, then put them on a morning dose. If it goes even finer, then put them on an afternoon dose. And then you move to I always move to the timed release after. Some people will start with the time release. They think that is a better route to take because it's a smoother delivery. All I can say is if you get a bad response, it's better to have that for 2 hours than it is for 8 hours. So be cautious starting in with the extended release formulations. When you do, though, use those extended release formulations, it's to accommodate to the kid's disorder and to their lifestyle for the family. For example, if a child only has problems in school, you know, that's it, really. I mean, I know you have to have it in two contexts, but if the main problem is school, then you're going to want to locate the majority of that effective dose of that medicine during school time. And so that means that you want something that lasts from early in the morning until about, 3:30 in the afternoon. And the way these medicines are done, you probably will find something that is approximately helpful in that. Also, and I don't know if you can see it on there. Yeah, it's sort of got cut off a little bit, but drug holidays. Drug holidays are basically when you take the medicine when you need it, and then you don't take it when you don't need it. A lot of parents will not give these medicines on the weekends, or they won't give them for summer break. That's perfectly fine. In fact, it's a good idea. It probably lowers some of the tendencies toward tolerance that you might get. However, it isn't always possible. If the kid is problematic, you know, and everything from home life to siblings to friends, then it's a 24-hour kind of thing, and you're going to want something that's much more extended. You're going to want something for the morning that lasts all the way to dinner time, or maybe even all the way through homework. That's a little hopeful to be that targeted. However, it all has, the drug holidays and the extended release both have to do with the lifestyle and the predominant kind of symptom profile of the child. These are things people will not tell you, but are just recommendations. Start low and go slow. Test the waters before you jump in with this. Use intelligent trial and error, because you know what's going on. You know how these medicines are going to work. But the fact is, we don't always know with which kid what medicine and what dose is going to work. And I always try to engage the parents with that as well. I always admit to them straight up front, you know, this is going to be a guided trial and error, and we're going to find out which things are helpful and which things are not. That means that you follow a kid really closely at the beginning. You know, you want to hear from them. You know, frankly, I'd rather hear from them after the first week of prescribing, just to find out if there's side effects, to find out if there's any beneficial effects. And so you see them frequently, and you change the dose frequently, or change the medicine if there's side effects. And then once that dose is established, then you don't want to be seeing them frequently. Because when a kid is on a stable dose of a stimulant and is doing well in school and all they need is a refill, honestly, they don't want to see you every month. You know, maybe you're doing something else with them, however. Maybe you're a therapist as well, and there's other things you're working on. However, for the most part, I try to be very hands-on at the beginning and a little bit hands-off afterwards. I'll tell you how you can do that with Schedule II medications in just a bit. Also, develop a relationship with the child as well. Kids don't like taking medicine. A lot of them resent it. They can't figure out what in the heck is wrong with the people who are critical of them. And so, you know, you'll ask kids, do you have problems in school? And they'll say, no, but my teacher is mad a lot. And then when they get better, this is the most amazing. This is an actual conversation I've had. When we got that kid to the point where things were going much better in school, and he's really responding well to a stimulant, I said, are things better in school? He said, it's about the same, but my teacher is in a much better mood. See, and that's the way they look at the world, is like, are people mad at me or not? There was, I'll just say this, because we're going to go into, I'm going to try to land right at 6. But we will look at non-stimulant kind of medications for that, because there are a few that are quite effective. These UK researchers looked at a meta-analysis of every single medicine, both stimulants and non-stimulants, that are used for ADHD. And what they found was that every single one of them was better than placebo. It's better to do something than to do nothing. You know, I don't mean that as a life rule. Sometimes it's better to do nothing. But in prescribing for ADHD, you usually are going to help things. That's what that research told us. I'm not going to list a whole lot of medicines. I underlined the ones that you're going to find most useful. That's funny. I thought I did methylphenidate first. Oh yeah, I did. Methylphenidate. So these are the options for methylphenidate. Remember, I said when they get around to tinkering with this stuff, they're trying to produce a different release mechanism and a longer kind of release, or a more targeted kind of release. And so I underlined, I know this is a very horribly made slide that we're all told never to make slides like this, but I just did it because I wanted to get all of the methylphenidate on one single slide to show you how many options there are. And this isn't even half the options. I got a couple charts later on that I'm just going to give you where there are options. I underlined the ones that you can most commonly get past insurance, and you probably don't need the other ones for the most part. There's immediate release, which we know you can get immediate release as a solution as well for kids that can't take pills. It has just about the same duration of action. We used to use Medicate, CD, commonly because it was probably, for a while, it was the best timed release, but most people have moved on from that. They find Ritalin long-acting, Ritalin LA, which is a 50-50. You got to know what these things are. They're a 50-50 mixture of this immediate release and a timed release. And the timed release are in these tiny little beads. And so for both, for Ritalin LA and several others, which I'll tell you, you can open the capsule and sprinkle it on their food. But however, you don't want them, if you chew those little tiny time capsules, they become immediate release. And so put it on something that they're going to swallow whole, like a drink, or, you know, kids, most of them eat cereal swallowed whole. So they don't do as much chewing as you might think, but just be careful when you're doing it, but you can do that. It's an easy way to get that medicine into the kid. I don't mean by trickery. I mean, if they have trouble with capsules or with pills of any kind. The other one I want to point out in here is Concerta. Concerta is a brilliant little package. It's basically methylphenidate, immediate release, but it's put in this hard little shell, and they bore a hole in it with a laser, and that laser just by osmotic pressure releases it at a certain rate. And so you consistently get about 12 hours of action from Concerta. Also, since I practice a lot with in juvenile delinquent facilities, there is always the game going on is how much medicine can you get and how can you abuse it? Concerta is very difficult to abuse. That little shell is hard, and by the time you get the methylphenidate out of there, you've destroyed it, and so there's nothing left. So I do recommend Concerta. I think it's useful. One of my colleagues reminded me that Datrana, which is a patch, I say my arm, but actually probably go on the kid's hip. Datrana can be really useful because one of the side effects that kids might have is GI. And I don't mean the anorexia, but it'll give them, for younger kids and sensitive kids or anxious kids, it'll give them kind of stomach pain or it'll give them nausea. So Datrana is a way to do transdermally. It works well. If you keep that patch on for 9 hours, you get about 10 hours of usable stimulant out of that. And if you decide, you know, if the kid comes home at noon on their half day, just pull the patch off and it's done. And it's not like off on, of course, you know, it's not like they suddenly resume their own behavior, their old behavior. But that's Datrana is probably a good thing to know. Quillavant, I'm not even going to go into. Quillavant XR has an enormously long, it's like 12 to 13 hours. It's a liquid. I don't know how they make it. But Dexedrine, and these are the options for Dexedrine. There's always Dexedrine immediate release, which is still around. It has 3 to 4 hours of duration. Usually though, when you're using Dexedrine, and some people choose this exclusively, they start with Adderall. And like I said, Adderall is a mixture of salts and it has a slightly slower duration of release. So it'll last like 4 to 6 hours, and then they will switch to Adderall XR, which is a nice upgrade, and that has like 10 to 12 hours. Again, Adderall XR is made by a racemic mixture of, meaning the right and the left-handed isomer of this medication. It tends to be, it's got an immediate release bead and an extended release bead, and they mix it at like pretty much a 50-50 mixture, and you get that 10 to 12 hours of duration. The other thing that is really useful, I highlighted Concerta when we're talking about methylphenidate. Vyvanse is a very creative and very usable kind of medication too. And the reason why is Vyvanse is a physiological release. And so it's not really in its active form. It's lisdexamphetamine, which is an added methyl group or something like that. But when you send it through the stomach enzymes cleave that off and part of it gets released. The part of it that gets sent through the bloodstream continues to be released by blood enzymes. And so you get this smooth physiological release that can, again, last from like 10 to 13 hours. And so it's very usable, hard to abuse medication. I mean, you can just take a ton of it and abuse it. But for the most part, it's not as abusable or misusable. Those are your options for those two medications. These are other options. I'm obviously not going to go over this, but I just put them on there so you'd have them. And it gives you, you know, everything that I could find that was current as of last year. I'll guarantee you there's more that are coming out. And you can see how many there are. These are all preparations, but it gives you the duration of time. It gives you what the underlying medication is. Now, using stimulants legally. I'm not going to go into this at length because I do want to cover at least some of the non-stimulant preparations for ADHD. So you've probably, a lot of you use, does everybody here use in some form or fashion Schedule II medications? Probably, I would think so, and in some form, because there's no difference between this and opiates. Or codeine. Oh, actually, codeine's a Schedule III or something like that. But nevertheless, there's no difference between that. And that means no refills. I'll come back to that one because there is a way to get those refills in there. No phone prescriptions except in emergencies, and ADHD is never an emergency, I guarantee you. No, and you can use electronic prescriptions. People who work at UNM, I don't even know if you guys are from Albuquerque or not, but people who work at UNM, they want everybody to use electronic prescriptions. However, that's not always possible, and written prescriptions are still valid and usable. When it comes back to the refills, remember I said when a child has reached a stable dose and they don't want to see you every single month, what they would have to if you follow the DEA rules. The DEA now allows you to write one script for the month and then 2 other scripts. So you've got 3 months of scripts, and those 2 other scripts have to have the date. You date them the day's date, but you write on there the earliest date at which they can be filled. I started to say cashed. The earliest date they can be filled. So you can effectively give 3 months of a prescription. And then those are the 12 required prescription components. Most people don't know that you really are supposed to have not only your address and contact information, but you're also supposed to have the patient's. Sometimes that slips. Thank you very much. I'm obviously not going to read those to you, but they can be useful if you're writing one of your first scripts ever for stimulants. Just make sure. Prescription monitoring program. I did want to say that this is a state-run, a state-governed. It's a national program, but it's state-governed. And I'm sure all of you probably have prescription monitoring access. And the rules are, in New Mexico, is that you have to check it before you first prescribe it, before you first prescribe a Schedule II, which in this case is stimulants. And then you have to check it every 3 months once you're continuously using it. If you don't see the patient after a gap of 30 days, then you need to check it again. And you know what they're looking for. They're looking for people that are filling scripts all over town. And they're also looking for dangerous combinations, which is helpful as well. So state law says you have to check it as often as it says there. Alternatives to stimulants. There's only really three I'm going to go over. First is Strattera, atomoxetine. It's not a stimulant. It is FDA approved. There is some, you know, you don't get as robust a response, but you do get a response. And sometimes that's what called for is a mild enhancement of attention. So it is FDA approved. It's got some research support for it. It can take a while to work. And it was initially, it was invented as an antidepressant because it's a norepinephrine reuptake inhibitor. It means leaves more norepinephrine, more stimulant in the synaptic cleft. So they invented that as an antidepressant. It didn't work, but it does work for ADHD. That's the story of pharmacology more often than you know. There are some side effects. There's not horrible side effects for this. I've had a couple of kids who had some pretty serious misery from atomoxetine. But for the most part, Strattera is easy to use, easy to start, easy to stop. These things like appetite loss, insomnia, headache, those are usually a small percentage and not that much higher than placebo. There is a black box warning, like I said, and this one is for suicidality because it's a lot like an antidepressant. The next one is Clonidine and Guanfacine. Clonidine and Guanfacine, those of you that are doing physical medicine, you might use those for hypertension. What they are is, they're central alpha 2 agonists, which really what that means though, they work in the brain, they cross the blood-brain barrier, but they reduce peripheral sympathetic tone. And what that means for blood pressure is it slightly drops the blood pressure. What that means for impulsivity is it sort of like takes the edge off it. And so those are particularly good with hyperactive, impulsive kids. They're not that useful for attention, frankly. And partly that's because they tend to be a little sleep-inducing. They can make a kid a little sleepy. A lot of times we use Clonidine or Guanfacine as a sleep aid for kids that have ADHD, and they might be taking stimulants during the day and Clonidine at night. I mean, and don't get them, I don't encourage at all the idea that, you know, you stimulate them during the day and then you sedate them at night. I don't mean that. What I mean is these are pretty mild medicines used, and they're mainly renally, for the most part, renally handled. And so the side effects are pretty minor. And if you have them, then you just stop using them. The side effects, obviously, since it's a blood pressure medicine, might be hypotension or particularly orthostatic hypotension. And if so, they're not going to come in saying, I have orthostatic hypotension. They're going to come in saying, I get dizzy, I get a dry mouth, I don't feel good, I get a headache after that. So you have to watch it. And if you get up to higher doses, you need to watch for rebound blood pressure. And then the third category is Wellbutrin, Bupropion. I think probably a lot of you know or have prescribed Wellbutrin for smoking cessation. It's a norepinephrine dopamine reuptake inhibitor, a common mechanism, but it also blocks nicotinic receptors. And so it does work for smoking cessation. Research says that it is a help. And it's got some modest research support for ADHD as well. We used to use this a lot more, and sometimes it's a lot better in its immediate release form because you're used to seeing as Wellbutrin SR, the sustained release, but you can give it immediate release for younger children in low doses. And sometimes that's all it needs. Sometimes it's quite a help. It also, because it's an antidepressant, it spans the gap. Okay, does that say 3 minutes or 0? Oh, 5? Okay, good. I thought, wow, they told me when I had 0 minutes. Let me see, what else am I going to say? Oh, yeah. Wellbutrin, it can be abused, but it's unusual. And if a person is in an incarceration facility, I always have to refer to that. They'll do anything to get Wellbutrin because they can, you know, abuse it in that kind of setting. And it gives, if snorted, it gives this sort of like mucosal anesthesia that, you know, is reminiscent of cocaine. And so, but nevertheless, it's not a highly abusable medication, certainly not for outpatients. There are side effects to this, and this is my last, well, no, I've got two more. This is my last slide. The side effects are, it can be agitating. It can cause sleeplessness because it's, you know, it's increasing. It's a norepinephrine reuptake inhibitor. It can cause insomnia. Seizures can happen, but usually only in the context of abuse. The last thing, this is the last thing I'm going to say, is they have studied the long term. These are always the most interesting study. This is the MTA, the medication treatment of ADHD. It's a multi-site study where they studied it for 8 years. And these are always the most interesting because you want to know, what does this become? What happens when you treat them? What they found was that at the beginning, medication is effective and medication plus therapy is the most effective. And therapy alone isn't as effective as medicine, but it does have an effect. However, that benefit for medicine tended to wash out after a couple of years. And so you would see that there wasn't the same benefit, that you might get longer duration of benefit from therapy as well, if you can get a kid to do it and get the parents to stick with the kind of principles. And it does not, over the long run, what we're addressing is immediate problems, frankly, because people with ADHD tend to have more life problems. Like I said, they have trouble, worse trouble, they don't all have trouble keeping jobs, but they have a lower propensity for long-term job retention, long-term relationship retention, that kind of thing. And so that is true for ADHD as well. And so the main factor is how well you treat it when you first start into it. Thank you. I appreciate your time.
So does anybody have any questions for Dr. Davis? Burning questions? Going once, twice? All right, it's quitting time on Friday night.
Yeah, that's
Thanks.
what I was saying. Go get some dinner.
Yeah. So before you leave, just two things. You do need to complete an evaluation for each day. So if you were here yesterday, you should have gotten an email yesterday that you needed to complete an evaluation. If you came today, you'll get another email. People ask us a lot of the times, why do we have to do an evaluation every day? And I'm going to tell you now, and then you can tell all your friends. The reason is people don't always come to the whole conference. Some people are coming one day, some people are coming 2 days. And so in order for us to keep that straight, we do have to do it daily. Now, tomorrow's going to be really interesting because we're going to run 2 rooms at one time. So you'll get to pick and choose where you want to go, what you want to see, what interests you. And so those evaluations will be blocked out. So it'll be interesting.